Good morning, everyone. Welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is 2025 Proposed Rules, Part 3, Medicare Physician Fee Schedule. This is Part 3 of a four-part series focused on the proposed rules. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the questions pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional questions. We will respond to questions posed after the webinar via email. We've posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you'll receive an email later today with a copy of the slides and a recording of the webinar. With that, I would like to introduce our presenters, Valerie Rock, Carine Leslie, Brian Raabe, Katie Croswell, and Kimberly Campbell.
Thank you, Jennifer. Appreciate everybody joining us today. This is, like Jennifer said, our third part of our proposed rule series, but this is our second part of the physician fee schedule. We actually do have one part left, so we'll be giving you all the details on that, and then we'll be starting the final rule rounds after that. So we're excited to share where we are at this point and a little bit more detail into more of the proposed rule. So if you didn't hear the session back on the 31st of July, go to our website and check that out, where you'll learn more about the reimbursement changes, the 60-day rule, telehealth changes, advanced primary care management services, and RHC and FQHC services. So there's still a lot there, and then we're going to add a lot more to that today, but we wanted to make sure you're aware of the key changes. It's not everything because it's a 1,000-page rule with subdivided into 3 parts on every page. So it's a very hefty rule, but we want to give you as much as we can in regards to what's coming and what to think about. Like, what are our questions? What are we thinking about as we read through the rule, and what do we expect to happen, and where are we not sure, and what you might want to think through. One aspect that we want to make sure that is super clear that we mentioned on the last session, but just want to bring it up here in case you did not listen to that last session, is regarding the telehealth requirements. That while it's not related to the physician fee schedule, if there's no congressional action by the end of the year, 12/31 of 2024, then we will have a retraction back to, or snap back to, the original requirements for rural health and facility-based telehealth services. Now, we don't expect that to actually follow through. We expect that there be an extension or some type of change to the requirements, but that is in Congress's hands, so we want to make sure you're aware of it. Don't change everything at this point. It's expected that it will go through, but it will be part of the the government funding discussion that we know is very heated at the end of the year. So it may be that we have, like we had at the beginning of this year, a month or two where things are still being negotiated, and then they finally are made final, and then maybe retrospective back to January 1. So just watch for all of that to occur over these next few months, because that is a big big change that could happen. So another thing is that we'll be dealing, or we did cover those inpatient and outpatient proposed rule changes in the July 10th session, and we'll be covering the finalized pieces in September. Get this next slide up. Oops, sorry. So want to make sure you're aware of our team that's on the line today. Again, I'm Valerie Rock. I'm joined by Carine, Brian, Katie, and Kimberly. All of us are part of a management team that serve our clients related to revenue integrity, compliance, and reimbursement areas of expertise. So we're happy to be here to share what our thoughts are in regards to this proposed rule. So today we're going to cover global surgery payment accuracy, the G2211 expansion, preventive and behavioral health services, supervision related to outpatient therapy services, opioid treatment program changes, and skin substitute changes. As we're talking through this, write down your notes and your thoughts because there may be an opportunity for you in thinking through how to comment on this proposed rule, reading through it again and making sure those areas that impact you most, that you're commenting on those, and you have until September 9th to do that. So we've provided a link here so that you have the opportunity to respond to that as well. So again, as I mentioned, the part 4 of the series will occur on August 21st. We'll cover the last part of the physician fee schedule on quality payment programs, Medicare shared savings programs, SDOH services, and clinical lab fee schedule changes. Then we'll kick off our final rule series on September 4th. So be watching out for that as the inpatient final rule is explained. So I'm going to turn it over to Brian to talk through these global surgery payment concerns. This is really the heaviest topic of what we're going to discuss today, so we're going to give a little bit of time to it. This could be a big sea change in how we do global surgeries, and it's in response to something that's been occurring really over the past 10, 11 years. So Brian, you want to kick things off?
Yep. Absolutely. Thank you, Valerie. And again, to reiterate what Valerie mentioned, thank you to everybody for joining today. We look forward to sharing these insights with you. As Valerie mentioned, improving the kind of topics that are covered in this section about global surgery payment accuracy. There's quite a bit to cover, so we'll do our best to hit kind of the high points for you here. But want to start just reiterating that, as expected for 2025, there's a number of topics that are revisited from prior years, as well as some new commentary and some new proposals, changes to this topic. So kind of the basics, just to kind of set the stage a little bit. Within the physician fee schedule, there's over 4,000 CPT codes that are currently categorized and valued as global surgery packages. These kind of, by the name, these generally include the necessary services that are typically provided by a physician or members of the same group practice as the primary physician. Any services that are tied to furnishing that particular procedure. These are currently broken out into 3 different categories. They're single CPT codes that are broken out into these, are defined rather as one of 3 categories, the first of which being a 0-day global period, which sounds kind of silly to say, a 0-day, but it's essentially referring to a 0-day post-op period. These are typically endoscopy services and some other minor procedures, but there, as you could guess, there is no pre or post-op period associated with these services. Typically a visit on the actual day of the surgery, or the procedure rather, is not going to be payable as a separate service. From there, you move up to the 10-day period. There's no pre-op period associated with these services, but there is a 10-day post-op period, which begins immediately following the day that the surgery takes place. And then the last one is the 90-day periods. These include 1 day prior to when the surgery takes place, and then a post-op period of 90 days that begins like the 10 days immediately following that surgery day. As we mentioned, these packages include pre-op visits, the procedure itself, these different components, and discharge services when applicable, as well as services provided, anything related to the procedure itself. Valerie, if you can go to the next slide, please. Also, kind of before we get into some of the changes for 2025, thought it would be helpful to quickly recap sort of some of the prior discussions and prior topics that have gone on over the years, certainly that helped get us kind of to where we're at today in expect to go for 2025. To start, in 2015, there was a kind of a big change that at the time, the 0, 10, and 90-day packages were in place. The proposal then was to take the 10s and the 90s and essentially convert all of those services to 0-day global packages, which effectively gets rid of the global surgical package concept. But the thought here being that you would essentially end up with, the proceduralist would bill for the surgery using the corresponding CPT code like they do today. And then any service outside of that, pre or post-op, would be billed by the provider that furnished that service. So it would be billed separately. Congress would go on to ultimately prohibit this. This is actually finalized, but the implementation of it would go on to be prohibited, leaving us then to continue with the current kind of landscape with the 0, 10, and 90 packages. In 2017, the process began of collecting data. CMS began looking really closely at Part B claims data for a number of things, primarily to look at the count and the level of post-op E&M visits. The idea being kind of started by or kicked off by OIG research that found that providers were typically not performing or performing fewer post-op follow-up visits than were expected and were accounted for during the process of valuing the global surgery package. Some quick stats to share. The result of that research and the data that started in 2017 found that for 10-day global packages, only 4% of the claims that they looked at utilized all of the E&M visits that are allocated and expected for those particular codes, and 38% of the 90-day global packages were reported using all of the E&Ms that were allocated for them. The other concern that came up that's come up over the years and kind of been revisited is the idea that the current global packages are based around and the structure of them is based upon one single model of care, and that's essentially the idea that a single practitioner is performing, or a practitioner within the same group practice and of the same specialty is performing the entire package. So said differently, it's not considering instances in which the procedure and post-op follow-up care are furnished by different practitioners, different specialties, or within a part of a different group practice. So where are we going with all of this? What's the goal? For 2025, there's a couple of changes that are being proposed, and really both revolve around the transfer of care concept and policies that are currently in place. The first of which is to revise the current transfer of care policy to specifically address instances in which the surgical procedure and the post-op follow-up care are furnished by different providers, specifically when there is no formal, but there is an expected transfer of care. The words that you see on the slide in blue text were specifically chosen, I believe, but were pulled directly from the proposed rule. And we'll talk a little bit more about kind of the thought process that we suspect is behind that, and why these words were chosen. But again, just to reiterate, addressing change or to cover changes where there is not a formal documented transfer of care, but they expect there to be one. The second change that's being proposed, or new topic that's being added for 2025, is to develop an add-on CPT code that would account for the additional resources involved when providing post-op follow-up care for that practitioner that did not furnish and was not part of the same practice and not involved with the surgical procedure itself. So said differently, in blue text when there is no formal and unexpected transfer of care from the proceduralist to the provider providing the post-op care. So kind of to dig a little bit further into the scope of these services and how they're kind of divided up and sort of the basis for these changes that CMS is proposing. Currently, under current Medicare policy, the scope for global surgery packages extends, as we mentioned, to the physician, the practitioner that provides that furnishes the procedure itself, as well as the providers within their group practice. As always, as it has been the case, and we anticipate will continue to be the case, there's certain modifiers that can be used to separately bill for services that were provided during the global period, but not related to the procedure itself. So some examples that are probably familiar with would be modifier 24 that can be used to bill for an unrelated E&M visit during the post-op period, and then as well as modifier 57 to capture the visit where the initial decision for surgery is taking place. So don't anticipate a change there necessarily. The big takeaway or kind of concept to make sure we've got a grasp on for related to the transfer of care modifiers is that how they can essentially allow the global package to be split into 3 different components. Those being modifier 54 captures the surgical care only, so that would include any day of pre-service activities that might be required, as well as day of recovery care. The post-op period or post-op care would of course include any E&M visits or discharge services that might be applicable, and then kind of the lesser talked about component is the pre-op care that would include E&M visits on the day of surgery when we're talking about a 10-day a code that is considered a 10-day global package and day prior to the procedure for 90 days. And it's interesting, this pre-op modifier 56 has been in place for a long time. It's in place as we speak. But depending on where you look, guidance doesn't really cover it, doesn't really talk about it. In fact, one of the things that kind of cross-reference the proposed rule with is CMS's global surgery booklet. And it acknowledges obviously this pre-operative category, but only offers guidance and only covers cases in which the transfer of care is occurring between the proceduralist, so the surgical care, and the post-op components. And then when these modifiers are reported, the global package itself is adjusted based on the percentage, and it varies from code to code, but it's noted within the RVU file. We dropped a quick table in here, just picked this is current as of the 2024 RVU file, but included CPT code 27130 for a total hip arthroplasty. This particular code is a 90-day global period, and you can see the pre, intra, and post-op percentages that would get applied, kind of show you the distribution of those specific services based on the modifier that's appended.
Brian, I'll just kind of reiterate what you were talking about with the pre-op modifier, that it appears that everyone interpreted the guidance from Medicare that Medicare does not allow the preoperative modifier, and in fact pays the preoperative portion within that surgical care only modifier 54. So if you're billing the surgical code with the modifier 54, you're getting paid for both of those initial 2 components. The postoperative care would pay for that last component. So that's something we need to request CMS to clarify, is how they want us to bill for that. Are they going to expect us to bill both components separately? If we're doing the pre-service and the surgical service, and then the postoperative by the other provider, or are we going to continue to get paid for the pre and surgical components, that intra-service component, with that one modifier 54. So that's something we need a little bit of clarity on as we go through to the final rule.
Perfect, thanks, Valerie. So still talking about on the topic, on the subject of transfers of care, the current policy for transfer of care, these transfer of care modifiers are required to be appended to the CPT code when there is a formally documented, coordinated transfer of care between practitioners that are involved. So an example, formal transfer of care is coordinated between the proceduralist and another provider. For the post-op follow-up care, both of the providers in this case would report the surgical code with the same date of service, and then would append, of course, the modifier that corresponds to the component that they were responsible for. And then, as Valerie mentioned, kind of some interesting takeaways that were shared regarding the claims data that was looked at to help inform some of these changes and proposals. A look at an analysis rather of 2022 claims data. They found a disproportionate number of claims with that have the 54 and 55, so surgical care only and post-op only modifiers appended. You probably guess, but in a perfect world, you would expect to see the same number, because for every post-op only claim, there would then be, you would expect to see a surgical only claim. Also interestingly, or to continue on that real quick, that obviously suggests that there could be either they're not being captured correctly, or modifiers are not being appended when they should, or providers may not be recognizing the need or able to anticipate when that transfer of care might happen. Also, interestingly, 99% of claim lines that were reported with the modifier 54 for surgical care only were related to ophthalmology services, specifically cataract-related procedures. And then, so what does it mean, and why kind of is the need? Why is there believed to be a need for these changes? The payment for the global package obviously is only adjusted when these modifiers are appended. And when the modifiers are not being appended correctly, that in turn generates, what's likely to be an inaccurate payment. And then further, kind of as we continue to rack up this claims data with essentially inaccurate, what are believed to be inaccurate, potentially inaccurate claims, CMS, is relying on these data for as a part of the valuation process for these packages. So it continues to just kind of evolve, and it makes it difficult to accurately assess. It's kind of how we got to the point that we're at, where it's hard to value, hard to determine where a change might be needed if the data we're looking at isn't accurate. I think we can move on. There you go. Thank you. CMS proposes to expand the policy to require that the transfer of care modifiers be used for all 90-day global packages in which a practitioner expects to only furnish a portion of the global package. So this kind of goes back to the specific language that we mentioned that's included in the rule, where where they anticipate there's not a formal but expected transfer of care. So this would, as you mentioned, include instances where there's a formal documented transfer of care. So that's kind of the current state of what's expected for these to be used, but then would also add these instances where an informal, non-documented, but expected transfer of care is going to occur. We don't anticipate, doesn't anticipate there's any change to the billing guidelines for separately identifiable E&M services. So that goes back to the modifiers that we talked a little bit about. And then CMS is currently seeking comment on also applying the same concept to services that are currently considered 10-day global packages. talking a little bit about the actual valuation of these services. Like a lot of the topics, CMS is essentially seeking feedback on potential approaches for revising the payment allocation. So that would be going back to the hip arthroplasty code that we shared, the specific percentages that are in there. One of the ideas, or one of the takeaways from the claims data analysis, was that rather than revaluing the codes based on the global packages based on the number of the M codes and the levels within that, there's just found there to be too many layers, and so the idea would be to just revalue that specific distribution. Exactly how they plan to do that is what they're seeking feedback on, and open to suggestions, of course. Also, in the process of reviewing the kind of the categories of global packages, 4 specific CPT codes were identified that are currently classified or categorized as 90-day global packages, but do not have a specific distribution or breakdown for the pre, intra, and post-op components. Those 4 codes are listed here. The radiation oncology services. So for these specific services, CMS is seeking comment on whether, one, should they remain 90-day packages or potentially be assigned, recategorized, and if so, if they should stay as 90s, how they should go about assigning that distribution for these specific services. The add-on code GPOC1 is kind of is the second bullet that we talked about in terms of one of the goals for 2025. CMS has proposed this code with, again, tying into the transfer of care policy, but the goal of this code is to reflect the additional time and complexity and resource costs that would be expected to be involved when a practitioner sees a patient post-operatively. So they're capturing that post-op care portion of the package after a surgical procedure that was performed by another practitioner. So the full, well, it's actually not the full definition, but a significant portion of the definition is on the slide here. This add-on code would be listed, would only apply to the 90-day, to procedural codes with the 90-day global period. It would be reported with a newer established E&M code. And I believe the next slide includes a summary of that the definition that CMS proposes for this code goes on to share some post-op services that that would fall into, that would be considered, would qualify to be reported with this code. Things like reading available notes and research, exam to evaluate kind of the current state of the patient postoperatively, in any attempt to communicate, or any work and time spent communicating with the practitioner to discuss the case. Some scenarios that they talk about where this might happen or that could potentially lead to this is, we talked about there kind of being an informal, unexpected transfer of care, and that could be primarily comes from the patient. The patient has an option to independently choose to follow up with a provider other than the procedural list. It could be following up with their primary care provider for a number of reasons, but that could be a case where that provider finds themselves having to treat this patient and provide that postoperative care without any involvement in the procedure itself or any of the pre-op work, anything like that. The valuation currently for this code is based on the existing CPT code 90785 for interactive complexity. It's an add-on code as well that was developed for behavioral health services. As they've stated now, it's believed that anticipated that the G code will be less and require less resources than the interactive complexity code that you see here. What they've proposed is they valued it at essentially half across the board. So half the work RVUs, half the physician time. So that's kind of what we would expect to see in terms of what the reimbursement for the proposed G code would actually look like. And then one last piece on this, the add-on code is the way they described it. It would not be reported by providers within the same group practice as the proceduralist or the same specialty. The expectation there being that these same resources, these same additional resources that we're talking about would not be, they wouldn't expect that those would be incurred in those cases. That would be, it wouldn't require the steps that you see here within the same group practice.
I know that's a lot to digest, and if we can break it down maybe into kind of 3 steps, we have a formal transfer of care with a real agreement that's documented, right? And so then we're following our normal processes with the modifiers and using the surgical code. The secondary option is we don't have a formal agreement in place, but it's expected that that transfer of care is going to happen. We're going to use the surgical codes with the modifiers in that case as well. The third option is it's unplanned and the patient basically shows up and you're providing post-op services for this patient, then you can bill an E&M with this complexity code. So we've got 3 basic options for this, and it, there's a lot of breakdown, a lot to, make sure that all of the details are there. But I think that as much as we can communicate to CMS in regards to our kind of expectations of what this would be, what the impact is to us, when we're actually trying to implement it, any questions that you have that you need clarified, ask them now so that we're better prepared to implement this in 2025. So thank you, Brian, for covering that complicated topic. Move on here to Kimberly. You're on mute.
Thank you. All right, I'll hop in for a few minutes, give Brian a chance to rest after that segment. So let's chat about G2211, which, as you recall, was one of the new kids on the block in 2024. Just a quick recap, this was the add-on, or is the add-on code for E&M visits. We have the official description listed here, but essentially it reimburses providers for that visit complexity related to either being the continuing focal point for all needed care, so think PCPs, excuse me, or when the care is part of an ongoing relationship to manage a single serious or complex condition, so your specialist. We won't get into all the details here for time's sake. Valerie actually went into great detail on this episode back in February, episode 64. It's on our website. Highly encourage you to go check it out for a deeper dive. But for our purposes today, we'll just stick to these proposed changes here. So under the current rule, G2211 cannot be billed with an E&M if other services are performed on the same day that warrant modifier 25. So an E&M is performed, a procedure or other service is performed same day, modifier 25 is added to that E&M, G2211 would not be billed. We've had questions as to why that is, and the thought process behind it, behind the current rule, is that those additional services, such as a procedure, are part of that complexity of care. So an additional reimbursement for that complexity would not be warranted on that same day. Now, there were concerns raised from commentators, as it says in the proposed rule, what happens when we perform preventive services like an annual wellness visit, or if we give a vaccine? Yes, we perform them on the same day. Yes, we have to add modifier 25, but these preventive services are separate in a way from the conditions being treated by that E&M visit that would then meet that G2211 code description. So they felt G2211 should still be able to be billed. The result of this, as it notes in the proposed rule, is that providers might just start doing these on separate days. So we'll bring the patient in one day, manage their conditions, bill an E&M and G2211, then we'll bring them back on a different day and do these preventive services, which of course is not ideal, and as the rule indicates, can actually disrupt commonly rendered care. if a patient can be fully treated in one visit, that's what our goal should be. So with that in mind, CMS is proposing that G2211 be allowed to be billed on the same day as an E&M if other services are performed, if those other services are one of these listed here. So an annual wellness visit, vaccine administration, or another Medicare preventive service. We would imagine based on this that CMS might start allowing other services as well, but we'll see what happens. I think we didn't put it on here, but just logistically, I think something to keep in mind if this rule is finalized is just make sure your claim scrubbers are updated. So right now, if they're set to auto reject G2211 with that modifier 25, just make sure that these preventive codes would be added so it doesn't automatically reject that. All right, next slide. So while G2211 gets revised, CMS has also decided to add another code into the mix, and this is currently GIDXX, which is essentially the same concept as G2211, but it's specifically for infectious disease providers treating patients in the hospital setting. So we have the full description for you here, which again, I'm not going to read for the sake of time, but in the bullet point, you'll see that from the proposed rule, the thought process behind having a code specific to infectious disease providers is that there's an increased work and a uniqueness that comes with treating these patients. So CMS felt that a specific code should be created to reimburse for infectious disease, as no current code, not even G2211, is going to cover this specific type of complexity. And then the projected work RVU value is 0.89. So Brian, if you're ready, I'll turn it back over to you.
Perfect. I am ready. Thank you, Kimberly. Almost ready. So the next topic, I think might be a delay on the slides. If the next topic that I'm going to cover is some new reimbursement that's being proposed for preventive services. Currently, so we'll start one of the big, this one kind of like the global packages is divided really into two sections, two categories that are where some updates are being suggested. The first of which relates to the hepatitis B vaccine. Currently, the vaccine is covered for individuals that are found to be at a high or intermediate risk of contracting hepatitis B. What CMS is proposing is to essentially expand the intermediate risk group to include and thereby cover individuals who have not previously completed a hepatitis B vaccine series, as well as individuals whose previous vaccination history is unknown. The other change that would come with this is that a physician order would no longer be required. Obviously, that is the case right now. The interesting thing about that is what removing the requirement for a physician order kind of opens the door for mass immunizers to be able to submit claims via roster billing for these services. So that would kind of move the hepatitis B vaccine into the same category as some other influenza vaccines and things like that. Those would be able to be handled and billed in a similar manner. No change is currently proposed. For the administration code for hepatitis B, it's the G0010. The only change being the potential rate changes, and that actually goes for the other administration codes or vaccine administration codes in this series. Those rates will be finalized will be set once the 2025 rule is finalized. Some of the other changes, again, back to the vaccine, goes for rural health services provided in rural health clinics and federally qualified health centers. Beginning on July 1st of 25, Part B vaccination claims for a number of vaccines would then be billed at the time of service, so kind of a claims-based method in which those services could be billed out of those facilities and paid essentially at the same when they're billed separately, they'd be paid at the same levels that they would be in other sites of service. The typical kind of payment methodologies for each of those respective entities, this would be billed separately from that, outside of those usual methods. The next slide. Perfect. The other change, one of the big changes that is being proposed for 2025, interestingly, since it relates to drugs that are covered as additional preventative services. I believe it's 2008 is when a law was passed in 2008 that allowed drugs to be added drugs essentially as a benefit category of additional preventive services. However, historically, up until now, Medicare is not paid for services under that category. So that's kind of the big changes, that certain drugs would move into that benefit category and be paid accordingly. To do that, they're proposing what I have yet to hear it actually said out loud. So I'm calling it the DCAPS fee schedule, but obviously drugs covered as preventive services. And essentially this would be, you just move these drugs into this benefit category, allowing them to be paid as they propose. It would use the existing Part B drug pricing mechanism. So really the average sales price kind of methodology, which is typically Medicare taking the average sales price of a particular drug plus 6%. So that would kind of be, that's the proposed rate setting sort of for this, for the DCAPS fee schedule. And then alternative pricing methods would be used kind of as needed based upon the data, the specific drug and the data available. Essentially, if the ASP data is unavailable for a certain drug, payment would be based on the national average drug acquisition cost. If that's not available, payment's based on the federal supply schedule. And if that's not available, payment would be just based on the invoice price and kind of on a case-by-case basis by the Medicare administrative contractor. And then that same fee schedule, similar to the vaccines, that same fee schedule would be used, is proposed to be used in RHCs and FQHCs as well.
Thanks, Brian. I'm going to cover a couple topics now related to behavioral health. The first being digital mental health treatment devices. And this term refers to a software device that has been cleared by the FDA that's intended to treat or alleviate a mental health condition when performed in conjunction with behavioral health care treatment. So CMS is proposing to create 3 new HCPCS codes to cover DMHT devices, which is modeled after remote therapeutic monitoring, or RTM services. The first code is GMBT1, which would be payment for the supply of the device and initial education and onboarding. And then GMBT2 and GMBT3 would be add-on codes for each additional 20 minutes for monthly treatment management services. This proposed move would be a big boost for digital therapeutics like wellness apps. Next, I'm going to talk about interprofessional consultation specific to behavioral health. CMS is proposing the creation of 6 time-based G codes for interprofessional consultation specific to behavioral health, which could include a clinical psychologist or a clinical social worker. And it would mirror the current interprofessional consultation CPT codes that can be used by practitioners who are eligible to bill E&M codes. They can be performed via communications technology like telephone or internet. The treating practitioner must obtain the patient's consent in advance of these services. And the proposed G codes would be valued similarly to the 6 CPT codes for interprofessional services by practitioners who can bill Medicare independently. The hope is that these codes will help integrate behavioral health treatment into primary care and other service settings. I'm now going to pass it back to Kimberly, who's going to speak on supervision of outpatient therapy services.
Thank you, Katie. Yeah, so physical and occupational therapy services are proposed to have a change in supervision requirements. Under the current rule, services provided by a physical or occupational therapy assistant are required to be performed under direct supervision. So that means the supervising therapist is present in the office suite and they are immediately available. The concern, as noted in the proposed rule, is that there's a shortage in both therapists and therapy assistants. So clinics are just not able to meet that demand of the physically present requirement of direct supervision. So to help resolve this, CMS is proposing to move to general supervision, which means the service is still provided under that overall direction and control of a PT or an OT, but they do not have to be present in the office. An interesting note is the proposed rule indicates this change more closely aligns with current state level supervision requirements. Currently, 44 states allow general supervision for PTAs and 49 allow it for OTAs. So we're seeing a closer alignment there. I'll pass it back to Katie.
Thanks, Kimberly. I'm going to be talking about 5 proposed changes for opioid treatment programs, or OTP as we refer to it in the next couple slides. The first is the proposal to make permanent the current flexibility for furnishing periodic assessments via audio-only telecommunication when video is not available. This was on a temporary basis during COVID-19, and so this would make it permanent if it were to go through. CMS recognizes that some patients have low broadband internet or no internet at all, and so they're more likely to use audio-only telemedicine services. The second change, CMS is proposing permitting OTPs to use audiovisual telecommunication for the initiation of treatment with methadone using HCPCS code G2076. But only if the OTP determines that an adequate evaluation can be performed via audio-visual telehealth platform. Next slide. The third change is related to social determinants of health risk assessments. CMS is proposing to provide payment for this when an OTP provider believes there's an unmet health-related social need or the need for services identified in the assessment could interfere with their ability to diagnose or treat the patient. The fourth change is that CMS is proposing to pay for 2 new opioid medications that have been approved by the FDA. The first is a nasal spray product called OpV, and the second is an injectable called Brixadi. Lastly, CMS is clarifying a billing requirement that OTPs must append an opioid use disorder diagnosis code on claims for opioid use disorder treatment services. So that's all I have, and now I'm going to pass it on to Carine, who's going to be talking about skin substitutes.
Thanks, Katie. So let's talk about what happened a few years ago in regard to the 2023 proposed rule for payment for skin substitutes. Back in 2022, when CMS proposed some changes to reimbursement for skin substitutes, they were considering a few things. They were considering creating a consistent payment approach for skin substitutes so that they were similar within the physician office and also within hospital outpatient departments. They wanted to make sure that the appropriate HCPCS codes, which identify the type of skin substitute product, were consistent between the locations and the settings that they were being performed in. They also wanted to make sure that there were uniform benefit categories across the products that are being utilized within the physician practice. So essentially, if a provider was using a synthetic or a human-based material versus an animal-based material, that there was consistent payment for those types of skin substitutes that were being utilized. And then lastly, to make sure that there was clarity on policies and procedures for skin substitutes. So what does that all mean? Because we've got to take it back to 2023 to understand what they're considering now. So essentially what CMS was considering for 2023 or proposing was to reclassify all skin substitutes products that were being utilized by physicians within their practice to be considered incident to a physician's service and package that payment into the physician's practice expense. And so from a provider perspective, essentially physicians that were providing skin substitute services and the products within their practice would no longer receive separate payment for skin substitutes under the ASP, or the average sales price. And essentially, in addition to that, it would change the HCPCS codes for skin substitutes from Q codes that are currently being utilized to A codes, which are the supplied code category. And then that, again, the skin substitutes would be considered incident to the physician service. While that is not the ideal situation, just from a reimbursement perspective, CMS did consider that. At the end of 2022, when the final rule came out, the decision was made not to move forward with that. However, for 2024, there were still considerations on how do we better value skin substitute services that are being performed within the physician practice. And so what CMS did for the 2023 proposed rule was to solicit more comments and identify ways that they can appropriately value skin substitute services within the practice expense for physician practices. And so what is the cost of that skin substitute? Research how much providers are spending, how much they're spending on the supplies, and if they could actually properly value that in order to essentially start reimbursing physician practices that are providing skin substitutes as they do in the hospital outpatient provider setting. And so as we ended 2024 for the final rule, they essentially decided they're going to continue to research and identify the best approach to determine the practice expense. Next slide, please. A few things that are happening or that happened through 2024 is that there are continued to be increased HCPCS codes, level 2 codes that are identifying new skin substitute products that are being utilized. And then in addition, in the calendar year 2024 final rule, the one change that CMS decided to make was to essentially exclude skin substitutes, say that 3 times fast, from being considered a refundable drug. Essentially, if their providers are not using all of the material, that they would not have to identify those on their claims as discarded medications or discarded drugs. The problem with that is that skin substitutes are difficult to identify if how much is being wasted, how much is actually being utilized. So not much has changed for the proposed rule for 2025. Essentially, CMS is still researching and trying to identify the best way to determine reimbursement for skin substitutes within the provider practice, and still considering if it should be considered incident to the physician service. The only component of the proposed rule for 2025 is that for 2025, CMS is going to continue to exclude skin substitutes from the discarded drug refund policy, which essentially states that if a provider administers a medication or a drug or a biological, that they must report that drug or biological with a particular modifier to indicate that they have not utilized the entire package. Skin substitutes are still going to be excluded, but CMS is continuing to evaluate that if that's going to continue for future rulemaking. And now I will turn it back to Jennifer.
So actually just invite you all to join us for our next regulatory roundup, which is August 21st of 2025 for our final proposed rule session, and then September 4th for our inpatient final rule session. And then we'll be continuing on as the final rules are released, and we expect this final rule for the physician fee schedule to be on or around November 2nd, as it is normally every year. So keep an eye out on these updates, and we welcome any of your questions as you have them. Feel free to include them in the chat, and we'll respond to you after this session, or feel free to reach out to any of us as well. So thank you for joining us today. Jennifer?
All right, thanks to our presenters, Valerie Rock, Carine Leslie, Brian Raabe, Katie Croswell, and Kimberly Campbell. Later today, you'll receive an email with their contact information and a recording of the webinar. Also, the slides and recording for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars, including the upcoming Part 4 of this topic, and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any questions you may have. On behalf of PYA, thank you for joining us and have a great rest of the day.